Hello, I'm Matthew Gavidia. Today on MJH Life Sciences News Network, the Center for Biosimilars is pleased to welcome Dr. Ali McBride, Clinical Coordinator of Hematology and Oncology in the Department of Pharmacy at the University of Arizona Cancer Center and past president of the ACCC. He is also the co-chair of the ACCC's Biosimilar project. To start off, it's clear that we're moving into the age of biosimilars. What does that mean for oncology practices and providers?
It's a multifaceted, so it's a great question. It's a multifaceted approach. Right now, with the advent of the number of biosimilars coming into the market, it provides open access to patients, which really means we're going to be driving down healthcare costs. In an age where we're looking at alternative payment models, we're looking at reducing overall total healthcare costs. The introduction of biosimilars provides probably the best option for that decrease. And as we look through and actually see the evolution of biosimilars in the US versus the EU and also European countries, we have other issues to address. And again, some of the things that we have faced with the US versus the EU is very different. We have a lot of different payers involved. Again, they have a socialized medicine system in some of the areas as well. But looking through this and kind of gleaming through in a very short and succinct answer, the biggest piece will be increasing access due to lower costs for our healthcare system, decreasing the national healthcare costs with biosimilar introduction in oncology, supportive care, and even, for example, in rheumatology and even for patients who have insulin. Again, another area too, where biosimilars are coming into play, as they've reclassified biologics as well, which just happened this year for 2020. The other piece, which is going to be the implementation of this process, is of course the focus on how do we integrate, which is one of the things ACCC has done a fantastic job, is the how to. And that will mean, looking at monographs, addressing formulary, looking at reimbursement, also understanding how it actually integrates in your IT system, especially for oncology drugs. It's a very large part of our workflow. Also delving into the education. We have a large number of people involved, physicians, nurses, advanced practitioners, pharmacists, just to name a few. But one of the key ingredients that we don't talk about is our financial advocates. We're always dealing with, let's get the drug out, let's give it to the patient. Is it paid for? Well, when we're adding on 4 to 5, maybe 6 biosimilars for one disease state, our financial advocates are the ones who are working on patient assistance, any copay support, evaluating anything else that may actually lead to free drug as well. So they have to get that information correct up front, as well as your coding and billing system as well. So the big piece is, yes, it's going to have a great influx, decreased costs, but the other end, really the back end work, the things being done behind the scenes, is going to be a salient discussion that will actually be participating among many stakeholders across the board. We have a large number of members involved in these discussions. ACCC has really kind of developed this workflow and modality about who's going to be affected. And I think we have a lot of different discussions to have probably over the next 3 to 5 years with education, of course, but also what it means to have this in a therapeutic arena, which is one of the areas that we're actually addressing right now, is therapeutic outcomes with oncology.
To follow up on that, the ACCC is launching an initiative to help with biosimilar integration into daily practice. Can you tell us a little bit about this?
The process pieces for the members involved, again, this is across the interprofessional healthcare team, really addressing multidisciplinary roles for biosimilar implementation. So we have physicians on board. For example, Dr. Patel is my co-chair on the biosimilar panel and committee here. We also have our nurses, our advanced practitioners, we have financial advocates, we have other pharmacists as well involved. So just looking at that, we have the A to Z of who's going to be involved in that committee. And that's the first step, right? Making sure we have representation from different members of the community practice and also our larger health system practice that integrates the information and also eases the way for understanding how to integrate biosimilars into the practice. And that's what we've done. We're starting on several initiatives which will be addressing the how-tos, as we talked about. But one of the things that we have to address is, what does reimbursement look like with the biosimilar? Are you doing that correctly? What does patient assistance look like? Patient assistance is a key piece of the puzzle nowadays with oncology therapies. Other areas that we have to address is IT, EMR systems, pharmacovigilance, which is a key issue across the board, which is really looking at the outcomes. One of the things that with biosimilars is a key initiative by FDA was to make sure that we address pharmacovigilance, which for many of us we've been doing in the pharmacy world for many years, are often called retrospective studies. So rather simply put, but we have the ability here to address that pharmacovigilance, really address the outcomes as well. But the education piece is one of the biggest areas we need to delve into. ACCC has put forth this piece of the committee to really address the education for all members, as well as patients who may actually receive these therapies, to really ensure that we all are on the same foundation or level for integrating biosimilars into practice. We are right now looking at 4 to 5 to maybe 6 trastuzumab therapies, bevacizumab therapies. We just had 2 rituximab-based therapies approved, with more coming online here shortly. So you can imagine some of the repetition that may occur, and also some of the issues that may occur with payers, as they may prefer one therapy over another. So really, for my presidency, I actually wrote a column called Biosimilar, the year of the biosimilar, which is 2020. And this is 2020, and we're already seeing the onset. And the amount of work being done by our healthcare teams, regardless of who you are, where you are in that structure, takes a lot of time to integrate these biosimilars into practice, because we have to address, okay, let's get the orders in correctly. We do that. We have our own formulary, but then the payer may have their own formulary. Well, that's going to cause some creation of havoc. So then we have to change the orders. We have to make sure that we can actually put those biosimilars into the stock and make sure we have it available to the patient, so we can actually bill appropriately based on that payer. You may also have issues with transition of care. We may know that in some cases, for example, you may be using a short-acting growth factor inpatient, may be discharged. You may get a short-acting growth factor outpatient. Well, you may get a different drug because you're working with an inpatient formulary versus potentially a specialty pharmacy formulary. So how do you work to really reduce any type of time associated not to get the drug, or that time to delivery of the drug? So we have a lot of work to do. This committee, with the members involved, which are actually leaders in the biosimilar field, we hope to really address what's happening in the community, and also the health system setting, to really reduce those burdens and barriers for implementation of biosimilars.
You kind of just alluded to this, but what are the biosimilar knowledge gaps that need to be filled in the oncology community?
Oh, that's kind of scary. I think it's not just oncology, right? We're talking about oncology right now, but it's actually oncology and non-oncology. Rheumatology is a big one. I think also with diabetes, we do have insulin coming down the pipeline too. We have a follow-on biologic, which did not go through the biosimilar pathway for long-acting insulin. We'll probably see more of those shortly. So really, it's across the board, right? Let me just say that very simple statement is an across the board lack of education. So we have about, like I said, 3 to 5 years of education to really pin down these issues. When we're looking at oncology, the biggest issues coming up is really education on these therapeutic areas. We often are not really educating the members. It could be the healthcare teams, the physicians, the nurses, pharmacy team members, technicians, pharmacy technicians as well, also being in this area. So we have a lot of education on what a biosimilar is. So going back to Biosimilars 101, we're almost there, but not there yet. Also addressing what is the therapeutic outcome of using a biosimilar. ASCO back in 2018, if I'm not mistaken, actually had a survey where they showed that a lot of the physicians did not want to use biosimilars in oncology for first-line therapeutic curative therapies. That has slowly kind of been reduced over the last year and a half when the recent survey came out. But that just means that there's an unfeeling, or how can I say it, a feeling of uneasiness when using biosimilars in this area, especially for therapeutic outcomes, which can be curative. Rituximab, trastuzumab, for lymphoma and breast cancer, respectively. So that's really kind of just understanding that. But other areas which I think hit the practices across the country is the pure lack of knowledge for reimbursement. And to me, I think that is across the board the biggest area that we can address. We see people who are experienced with reimbursement not be aware of pass-through status for biosimilars, not be aware of the potentials for these therapies in these areas, and also the reimbursement coming up front. And if you're in an alternative payment model, then again, with ACCC's experience in this area, this is an easy way to invest in the education area, is to really look at how APMs will actually benefit with the introduction of biosimilars and utilization for patients. And that will probably continue until the next iteration of OCM or OCF, as it's called, Oncology Care First, or may actually change thereafter. We'll see what happens there. But with that, we have now the means to reduce some of those costs of care, especially as biologic therapies continue to rise in price. And also with the advent of newer biosimilars, we'll see some of those introduction in these cases too.